Good morning, everybody. Nice to see so many people attending this PhD lecture, and I'm really honored and thankful to Dr. Santoshona for giving me this opportunity. I always wonder how you can sit from morning to evening listening to so many lectures, so many bombardment. It's quite a task to do that. But then I think about it, on the other way around, it's also very nice to see so many teachers coming up here to teach the students and take a day out, and that's really heartwarming. So my job is to talk about the investigative procedures in cornea and ocular surface. It's a very broad topic, and I don't think I can do justice if I try to keep talking about, can we go forward? Okay, so my plan is that I'll talk about corneal topography, simplify it, confocal microscopy, specular microscopy, ASOCT, and those things. Starting with corneal topography. Now, I don't want to teach you the theoretical part of how the corneal topography is done and what are the machines and all those things. What I want you to learn is, tomorrow in your hand, if you get a printout, how do you interpret? Or in your exam, if you get a printout which you have not seen earlier, how do you interpret this thing? This is what I want you to learn at the end of the lecture. Most of the time in the lectures like this thing, people will talk a lot of things and forget about putting down notes. If you can remember at least one important thing which you learn, new thing, well, you're done. So enjoy yourself, and we start with the corneal topography. Now, corneal topography, to know the shape of the cornea, we have traveled a long way. We started with an humble beginning of Mr. Antonio Placido's round disc, which we still have in most of our medical colleges, and they keep on the table also, God knows when they use, except in the exams. But how it is used? Well, we keep it in front of the patient, there is a lens in the center, and we see the first Purkinje's image on the eye. And where does the first Purkinje image come from? Did I hear anterior surface of the cornea? Wrong. Tear film. It comes from the tear film. The first thing which reflects the light is tear film. So if somebody does not have a good tear film, somebody has a dry eye or anything like that, you may not get a very good Placido image there. Now, what Placido image actually does is it reflects the light or those round circles on the cornea, and when you see it back, you see the shape of those circles. Now, if cornea is nice and round and spherical, which it is not, if at all it is, you will see nice round circles like this thing. But if there is any change in the shape of the cornea, like cornea is flat in some region, you will probably see in the top part, the circles are a little wider, they are a little larger, and that's very typically the flat cornea. Whereas when the cornea is very steep, you see crowding effect, and you see the circles are getting a little smaller. The same principle, after so many years of Mr. Antonio Placido's invention, we are still using in most of our current topographers. Those topographers which are based on Placido's device are still using Placido's ring. Now, they may have more number of ring, they have a small number of ring, but in principle, they use the same thing. Now, there are two major type of devices, Placido's based devices available for the topography. One is a bowl shape. A bowl shape device is a very large device which has multiple rings. And second one could be a cone shape, which is a smaller device. The advantage of bowl, well, patient can be sitting a little farther. But disadvantage, well, because it's such a big thing, you get a shadow from the nose, whereas in the cone type, you don't get shadow from the nose. Coming to the interpretation part, or a more interesting part. Now, before we jump into that, what I want you to understand is that any topography, most of the time what we follow the color coding is where the cornea is steep. Especially when we talk about Placido's based device, we always talk about steep and flat. Okay, and when we talk about elevation based topographer, we talk about elevated from surface, below the surface. Anyway, we'll come to that. So, if the cornea is steep, we'll see warmer color. If cornea is flat, we'll see cooler color. And a normal cornea would show that green color. Now, the most important slide of my entire presentation is this slide. And thanks to these two gentlemen, Rabinowitz and his colleague, they came out with a landmark article and said that any Placido's based topographer printout can be classified into one of these 10 patterns. You can have round, you can have oval, you can have superior steepening, you can have inferior steepening, you can have irregular pattern because of dry eye or irregular surface, you can have vertical bow tie with the rule astigmatism, you can have oblique astigmatism, you can have asymmetric bow tie with inferior steepening, you can have asymmetric bow tie with superior steepening, and finally our friend, that's asymmetric bent bow tie pattern or asymmetric bow tie with radial skewing. Why I said our friend? Well, most of the time in your exam, you're going to see this person only. Nobody is going to show you some non-specific image and put in front of you. I mean, I need to flaunt around how do I have nice topography. So I will show you something very interesting only. So obviously, you're going to get something like this, or maybe at the most with the rule astigmatism. So in your exam, when you're talking about your table viva, and when you have printout, well, be prepared, you might come across a keratoconus, and unless proved otherwise, that would be true, or we'll come to what second best can be done. Now, there are a lot of diagnostic topographic criteria has been reported in literature. I don't think I'm in mood to go through it, and neither I would advise you to go through it. One, what your teacher remembers, what you should remember. That's what is Rabinowitz criteria. Rabinowitz criteria, though it's oversimplified thing, but it's quite nice and quite simple. So as we see, the central power, which is very steep part of the cornea, is more than 47.2. Superior inferior asymmetry, if it is more than 1.4, and the axes are skewed. Both the axes are not in same line. And this is what Rabinowitz criteria is about. So let's go for the evaluation. Before we start evaluating this thing, these are the checklists we should have in our mind. Always look for the name of the patient, date, which you are examining. And this is more important when you come across a printout which is alien to you, which you don't know. You don't have any idea, you've not seen that printout, that topographer you've not seen earlier. So this is how you buy time. You take the printout in your hand, and obviously you know the name of the patient will be in one of the top corners. So start reading. This is the printout of Mr. Himanshu Matalia, age this, date this, which date done, whatever comes to your mind, start reading that. And after that, start searching for something like K1, K2, or sim K values, or steep K, flat K. This is the next thing which you want to jump over to. When you go to that thing, then you start applying your Rabinowitz criteria. Is it more than 47.2? Yeah, it looks like more than 47.2. How much is astigmatism? Okay, looks like fine. So it will probably give you a little bit more idea about how steep the cornea is. Now, if your K values are in 50s or something, you know it's so steep cornea, it has to be keratoconus, right? After that, you jump over to your topography, which we'll come to later on. You should also know about whether the patient is fixating properly or not. The major fallacy about these placidose-based topographer is if patient is not fixating properly, well, it can actually give you some wrong result and may simulate like a keratoconus. Also, whenever anybody gives you a diagnosis or something, another smart thing you always do, everybody teaches you that when they give you printout, do not commit about the diagnosis. You can say, I would like to know about the clinical data. I would like to examine the patient. I would like to know about the vision of the patient, refraction of the patient. Then they said, yeah, it's okay. Fine, go ahead. So in that case, I would like to put differential diagnosis. Very nice. So most of your printouts and all those things, you always rattle out these things because you obviously want to know patient because there are a lot of things which can fool you and which can give you a diagnosis of one particular thing where it's not there. So you also should be known about the color scale, what color scale they are using, the steps, and the statistical information. Again, before we go, remember this thing. Patterns, 10 pattern. This guy, Rabinowitz, forgot about the horizontal bow tie. I don't know why. He forgot about the against the rule astigmatism. Maybe in US they don't get against the rule astigmatism, but we do get. So we do remember 11 pattern. Remember from 10 and our friend asymmetric bent bow tie pattern. Now let's go to the first example. What do you see here? Loudly, otherwise I'll finish my 30 minutes so fast. Okay, I don't want to finish my 30 minutes so fast. So it looks like there is an asymmetric bow tie pattern and this thing. Again, I'm trying to remind you, go for your checklist. If you see here, Look at this thing. The Myas are not centered. This patient was not fixating. In fact, he was my PG. He was told not to fix it in the center. So if I superimpose both the things, the topography is not from the center, and hence it is looking like as if person has keratoconus. But when I told him to look straight, well, it looks like it's with the rule astigmatism. It's a vertical bow tie pattern. Looks fine. Now also you have one more thing. This surely is a keratoconus case. You have an asymmetric bow tie pattern with a steepening there, and the keratometric values are also quite high. But if you look at this thing, there are certain things which you are missing out. Those are these dots. These dot means there is a loss of data, and computer has just calculated data and put there. So if you actually see, this is how the actual topography is looking like, and you lose there is lot of data loss which is there, which is covered by the lid here, upper lid and lower lid. So that's also again good exposure is very important. The color scale, look at the color scale, looks like very advanced keratoconus, but if I change the steps, which are 0.25 steps here in the color scales, the moment I change, you see the change in the color of, well, it doesn't look like that bad to me now. So always pay attention to what steps which we are looking at. The type of map also would differ, because if we are dealing with axial topography or tangential map, well, they might have little difference. The tangential map is something which probably gives you a localized changes, but you know what, I don't like it, because it gives no two topography or no two person will have same tangential map, because localized changes can be so many. It will also not show those 10 images or 10 patterns which Rabinowitz told us that which we can see. So we cannot do a pattern diagnosis in case of any disease here. So I don't like this thing. That's the reason why most of us, though this is not the best, we like the axial method of topography. Also, whenever you have two topographic images, there's a phenomenon called enantiomorphism, which means a mirror-like image. So right eye and left eye both should look, but both them should look same. Well, this is not good. My photograph should be older one. Gavaskar younger one, and me old, not good. So if you see here right eye and left eye, well, they both are mirror images here. So most of the time such kind of patients are quite fine. But again, we should also remember what our friend Rabinowitz criteria told us about. So if I look at the drawbacks of all these placidose-based devices or topographers, well, they have limited data point. They usually can give you topography from the central, almost I would say 6 to 7 millimeters maximum. Beyond that, well, it does not give you anything. There's a camera in the center, so the bang center topography is actually simulated. It's not real. Also, you do not have any idea about what's happening in the posterior surface and pachymetry and so on and so forth. But it actually gives you true topography. This is how refraction from the surface of a cornea would be, or rather tear film would be. Now to help us out with this thing, there came the new generation topographers or elevation based topographer. They could do, the first came was Orbscan, and then Pentacam came across and swept the market along with that. But what it does is, it shows you the anterior surface of the cornea, posterior surface of the cornea, pachymetry, the entire analysis of anterior segment. And hence, probably, they are much more complete topographer. Well, I do not want you to remember any of these things. Again, second important slide in my entire lecture is this. Elevation-based topography can have two types of possible images or pattern. One is island pattern, which is regularly seen. And what do you mean by island pattern? Well, you see this yellow color thing is the cornea, which is usually prolate. That means it's little steeper in the center, little flatter in the periphery. If I try to put across a known shape where that shape touches this surface maximum, then probably I can say both of them are similar to each other. And maybe the radius of curvature of this shape will be the radius of curvature of my cornea. And this is what we do for planets, right? Earth, we say radius of curvature of the Earth. What are you talking about? Are you talking about radius of curvature from Pacific, or you're talking about from the Everest? But when you see Earth from probably millions of miles away, you'll see it looks like round, and you put a round shape on top of it, it looks like, oh, they are overimposing everywhere. Little bit away, looks like that's Everest. Little bit inside, it looks like that's Pacific Ocean. But that's what we do for elevation-based topographer. We probably put a shape there which mimics that shape. Anything which is above, that's the warmer area, that's the island. Anything which is below, that's the sea. So you can have island pattern in a normal cornea, or you think about if cornea is still out, makes a mountain, it's a red color, and even more than that, mountain kind of thing in the center. Where can you get that? Keratoconus, right? Keratoconic cornea would be projecting out so much. Well, rest of the area it's touching, but that area will have a mountain. You get the second pattern is saddle shape pattern, and this is typical pattern of astigmatism. So elevation based topographer, they have two types of pattern. One, island. Second is saddle shape pattern. Now let's take a printout of this is Orbscan printout. This is again the funky name of this thing is quad map. So when you want to flaunt around, you can say this is a quad map printout of Mr. Shah Rukh Khan, right eye, whatever this thing. So basically quad map printout, what we are looking at is here. The first map is, this is anterior elevation map, elevation based topographer. What kind of patterns you can see? Island or saddle shape pattern. What do we see here? Looks like island, well looks like normal cornea. This is posterior elevation, back surface of the cornea. Now we know back surface of the cornea is little more curved than the anterior surface. So obviously you will have little more elevation there. So what can elevation based topography again? How many patterns you can see? Two types of pattern, either island or saddle. What do we have here? Island pattern. Looks like little island but little warmer. It's fine, absolutely fine. Then we have something called curvature map. This is something similar to what our Placido based topographer was showing us. How many types of pattern do you see in Placido based topographer? 10 types of pattern. To make Rabinowitz happy, to make me happy, 11 types of pattern. Okay. So what do we have here? Looks like probably with the rule astigmatism. Vertical bow tie pattern. Well, it looks fine. Actually, it doesn't matter. And the final map what we see is the pachymetry map or the corneal thickness map. Here, well, it's intuitive. It's a corneal thickness. Whatever numbers you get, that's the map. Now here in the center part, again as I was telling you, you search for minimum K or maximum K, you get those things here. Forget about 3 millimeter, 5 millimeter zone, forget about it, it's okay. You go to thinnest area. This is the thinnest area which gives you a pachymetry of thinnest area. And that's what you want to see. Now the new topographer like Pentacam, again the topographer changes, the thing may look different. But you know what? It's the same thing. This thing, if you rotate it clockwise, this is what you get here. So you have anterior elevation here, posterior elevation here, pachymetry here, and the axial map or curvature map there. So simple again. So again we know that elevation based topographer, what kind of pattern you can have? Saddle shape pattern or island pattern. What do you see here? Looks like probably saddle shape pattern. What do you see? The back surface of the cornea looks like saddle shape pattern. Maybe looks like astigmatic cornea. What curvature map? What kind of patterns you can get? 11 pattern. What pattern is this? Okay, vertical bow tie pattern. Looks like it's with the rule astigmatism. Yes, we got the diagnosis. Yay. So let's go a little more difficult. I know, I mean, you guys are now born. You can just nail all these things down. So go map by map. First of all, Mr. Shah Rukh Khan's left eye and why I'm crazy about Shah Rukh Khan. Okay, let's somebody else's left eye and elevation map. So first elevation map, anterior elevation map. What kind of pattern you can get in elevation maps? Island or saddle. What pattern do you see here? Island pattern. And you see island, you see a mountain there. In the middle of the island, there is a mountain where, well, looks like there's something in the cornea which is like elevated. Good. On the anterior surface. Posterior surface, it's even worse. You go, you see red color, and beyond red color is this violet color. So it's even more than that. Both of them are in same region. Cornea is like out in that region. Interesting. Now this map, how many patterns you can see here? Possibly 11 pattern. What pattern do we see here? It's an asymmetric bent bow tie pattern. Well, that's very typical of keratoconus. Pachymetry, what do you see? 359, 319 thinnest cornea. What do we have? Keratoconus. Bravo, very good. So this is what we actually went about, and we got a diagnosis of keratoconus. Let's see one more map. Okay, I've already put the diagnosis here, so you know. Okay, still, entry elevation map. How many types of pattern you can see? 2 types of pattern, island or saddle. We have island here. Island seems to be fine. Posterior elevation map. What types of pattern you can see? 2 types of pattern. Island, but island is not normal. Island seems to be a little bit elevated. It looks to be having a little mountain in the center. So posterior surface having little elevation, but the anterior surface not having elevation. Corneal thickness being 463 or something. We are dealing with a former frustic keratoconus. So all these printouts can have different displays. This is called Bellin-Ambrosio display or bad display. Well, I don't think I have time to go into detail of all those things. Well, there are different topographers which have come into market recently where they use the elevation based topography and combine it with the Placidos based topography, something like TMS5 or Sirius. Their advantage, well, they are actually showing the real elevation based topography as well as the real Placidos based topography, because it's not a simulated one, what we have in Pentacam. However, it does not tell you about the aberration. Now, the in thing recently is aberrations of the eye. So we have even further generation newer topographers which show us the aberration of the eye, the topography, autorefractometry, pupillometry, and so forth. Except we do not have anything from the back surface of the cornea, which we could get in Pentacam and all those things. So that means we still have an opening for us in future. We have something which will have an elevation based topographer. Along with that, it will also have all those aberrometers. So we get a case of LASIK, and you get printout in front of you and say, doctor, can I undergo LASIK or not? So what do? Anterior elevation map. This is a quad map printout of Mr. Himanshu Matalia, right eye of Orbscan. What are you seeing in the anterior elevation map? Island pattern. Island pattern looks fine. Posterior elevation map. How many types of pattern? 2 types of pattern. Island pattern looks fine. Okay, forget about it. What about this thing? Axial map. Looks like it has vertical bow tie pattern. Looks okay to me. Pachymetry 556. Thinnest Pachy 548. Congratulations, sir. Okay. We'll discuss about that thing. How much significant skewing is significant to call as a radial skewing? We'll probably come to that. Otherwise, I'll not be able to finish thing. I just have 7 minutes, and I have a lot of more things to go. Pellucid marginal degeneration. This is another printout which you can get, because again, this is something which is very unique. Especially if I have to flaunt around, I'll give Placidos based printout for this disease, because that's where it looks nice. That bird beak sign, or kissing bird sign, or lobster claw sign, or butterfly wing sign. I mean, you can name anything, any possible thing. But basically, you have an astigmatism which will be quite high, horizontal astigmatism, and you have a thinning in the inferior part, and it would look like something called beer belly sign, where you have thinning below, but the most elevated part is above that. Now you take one more printout. Now this is an alien thing. We spoke about Pentacam, or we spoke about Orbscan. Now this is Galilei. Again, it's new for me. Now what do? Well, we start reading about, this is Galilei G4 printout of Mr. Nadeem Muhammad done on 9th, this thing. And I'm searching. I got K values. So steep K is 43.5 and 45, flat K 43, steep K. Looks okay. Go map by map. Read about anterior curvature map. This is our axial topography map. What kind of pattern you have? You have a vertical bow tie pattern. But you know what? It's such a small. If you look at the color code, the color code shows that it's quite steep in the center part. But because let's not disturb him. Okay, so the SIMK value usually is 3 millimeter. Hence, 3 millimeter is beyond this thing. That's why it's not picking up, and hence we are getting a curvature as normal there. But if you look here, well, it's definitely a steep cornea there. Well, interesting. You go to the next map here. It's a corneal thickness map, corneal pachymetry map. Well, there's nothing about that. Well, we have to see corneal thickness. We see the thinnest area showing somewhere around how much pachymetry? 455 or something. Well, definitely low pachymetry. For sure, low pachymetry, steep cornea. Probably we are dealing with a keratoconus case. However, I would definitely like to see this patient. I would definitely tell my examiner that I would love to see this patient, clinically correlate my finding, because the elevation based topographer takes a large shape which is fitting in most of the area. It's not picking up an island here. Right? So just probably to put that point across, I put that. Now again, what Rabinowitz forgot, we did not forget that you can have against the rule astigmatism also, but again you have same thing, you have a saddle pattern and the same thing. On Pentacam also you probably see the kissing bird sign of a pellucid marginal degeneration, but as you can see, rest all these are looking non-specific. What looks beautiful is the sagittal curvature or axial curvature. Now, last topography part I am showing you. What do we have here? Fast, I don't have time. It looks like keratoconus, but it's not keratoconus because this is called contact lens warpage. A lot of time, the contact lens wearer can have altered curvature of the cornea, and which actually fools you. So if this is the reason why I'll tell my examiner that I'll not give you diagnosis, I'll rather give you my differential diagnosis, and I would like to see my patient and examine my patient. So this is about the corneal topography. I do not have too much time, but let's go through something about the confocal microscopy. Now, confocal microscopy, basically what we do is, it's a big brother of specular microscopy. Now here in confocal microscopy, the principle is there, whatever the light comes out, a very bright light passes through a mirror, passes through a lens, which focuses it on the cornea. When the light is coming back, it passes through the partial reflectile mirror and passes through one more pinhole. So there are two pinholes, light passing through first pinhole and passing through second pinhole. So only light which is focused at that point, only area of my interest will be visible. The disadvantage, well, it reduces the illumination, so you need a very bright light or a laser here. But what you have advantage, well, you can see actually cornea layer by layer here, where you can see the layer by layer cornea epithelium, you can see the corneal epithelium, you can see the basal layer of the corneal epithelium, and so on and so forth. There are a couple of machines which are currently available, like HRT with the Rostock cornea module and ConfoScan from NIDEC, which can show you the image like this. This is the superficial squamous epithelium. Going further down, the basal epithelium, subepithelial nerve plexus, anterior stroma, which is much more cellular than the posterior stroma, and the endothelium. Endothelium, we know, has the hexagonal pattern. The abnormality, well, we can see nicely Fuchs dystrophy with Gutte there. In spite of having a very large number of Gutte and corneal edema, you can still do an imaging of this thing because it's confocal microscopy. Posterior polymorphous dystrophy or typical railroad or tram track sign you see on slit lamp, and on confocal you see a large defect which is excavated and you see bridging fibers and fibrillar deposition around. In same way in iridocorneal endothelial syndrome, well, you see an epithelialization of the corneal endothelium and you see kite-shaped cells, which gives you an idea that this cornea is compromised. You see in granular dystrophy, breadcrumb kind of thing or snowflake kind of dystrophy, which can also tell you how deep the dystrophy is, and similarly in lattice dystrophy also you can see that. In keratoconus, you can actually investigate about how the nerve fibers are oriented, and in scars, you can differentiate what kind of scar we are dealing with. Are you dealing with a subepithelial scar or you're dealing with a fibrillar scar? Also, it's very important to use it in microbial keratitis. In microbial keratitis, you can actually do a diagnosis of fungal keratitis or an acanthamoeba keratitis cyst, which you can see on this instrument. I'll touch up more importantly in your exam what they can ask you, specular microscopy here. The last part of ASOCT, I don't think it's so important. We'll just skip that part. But the specular microscopy, I'm not showing you the principle and those things. But specular microscope, there are various types of specular microscope available, contact and non-contact. Most of the specular microscope what we use are non-contact one. The non-contact one has a limitation that it will have a very small area of interest. But what you see here is the beautiful picture of endothelium. Now, endothelium, any area where you want to accommodate maximum number of cells or maximum number of things has to be in honeycomb shape. And that's how nature has made honeycomb also like that shape, hexagonal shape. Because you can utilize maximum area in a small, you can pack them in small region. So the ideal endothelium would be honeycomb shape or hexagonal shape. The endothelial count keeps going down with the age. And it's very interesting to know that endothelial count can be as low as 500 also, and you still can have functioning cornea. The analysis can be done by different method. This is more theoretical. I'm not going to detail of that. Like one is called fixed frame method. It is more chance of error, or you can have variable frame method where you highlight the corner of the cells, and which is a little more accurate. You can also have something called corner method where you calculate the edges of the cells and then you analyze that, or you can have central method where you put a dots into the center of the cells and then you do the rest of the analysis. Rest of the analysis is done by actually the computer, and you don't have to do. You can combine both of them together, and it's called center flex method. Now the important thing for us, when we talk about specular microscopy, these are the few things which we have to remember. Cell area or cell density, that's most endothelial count, what we call. Polymegathism or coefficient of variance, and pleomorphism or hexagonality. The important thing about coefficient variance is basically when the eye has variation in the size. So when the endothelium in some area is small, endothelial cells in other area is big, when you put them together, there is a lot of variation of the size between these areas. Hence, you have this coefficient of variance which will be little higher. So higher the coefficient of variance, bad the cornea is. So CV in a normal or coefficient variation normally is less than 0.3 or 0.7 to 0.28. In case it's larger, that means there is a lot of irregularity in the size of the cells. When the size is involved, we call it polymegathism. Okay, mega is a lice. Polymegathism. Now, the cells, as we said, the ideal cells should be hexagonal. If they lose their hexagonality, there probably the cells with 6A or 6 side would reduce in number. If it is less than 50% of total cells which you see, it may not be very nice, and probably cornea may not be very good. Hence, this is related to shape of the cornea, hence we call pleomorphism. So when CV is high, we call polymegathism. When 6A is low, we call pleomorphism. So you see the corneal density, everything is same here, but more the CV, you see the cells are bigger and smaller, or you see here where you have an ideal theoretical picture of an endothelium where the density is very high. The next picture also has very good density, but you see CV is 45 here, CV is 25 here. Look how nicely cells are, and the next picture has so much of variation. So that is, we are dealing with polymegathism. Pleomorphism, well, most of the cells would be hexagonal, but if you see them in different shapes, we call it pleomorphism. Also, you see guttae on the endothelium in case of Fuchs endothelial dystrophy, and which can probably be recognized here. So I'm going to finish with a couple of examples. So what do we have here? We have here, what do we have here? So you probably look at these things, numbers, CD, that's endothelial cell density, 1684. Well, it's little less only, definitely. CV, coefficient variance, normal should be 27 to 28. This is 50, very high. So person does have polymegathism. You see the cells are, some of the cells are bigger, some of the cells are smaller. So that's fine. 6A, this should be more than 50. It's not more than 50, it's 33. That means person has pleomorphism also. So maybe this is an ailing cornea or older cornea, And the individual cell average size normally is 250 micron, 250 square micron. Here it's like 500 square microns. So obviously it's an ailing cornea. We are talking about polymegathism and pleomorphism. So your diagnosis in your exam would be polymegathism, pleomorphism. Let's take about this thing. Mr. Shah Rukh Khan's, oh, not Mr. Shah Rukh, sorry. Ideally, I mean, this is Amitabh Bachchan. Now, who can have 832 count, man? At this age, obviously, he'll have probably this count. So, cell density is 832. Okay, this is the cornea, which is probably quite sick cornea. Maybe we are dealing with a corneal transplant case, or we are dealing with a really old person. Coefficient variance 31. Well, that's strange. Coefficient variation is normal. 6A is 55. Looks like probably fine. How can this be possible? Well, because the cells are so big. Now look at the average size of the cell, which should be 225. Instead of that, it's 1202. Huge cells. But most of the cells are similar. Most of the cells are still hexagonal. Hence, your coefficient of variation is coming to normal, and your hexagonality is also coming to normal. So basically what we have is low cell density area. Also, in cases like Fuchs dystrophy, you will see the loss of reflection, and you will see those moon kind of surface. Specular microscopy is also used in eye bank, but the limitation of the specular microscopy is that when the media is not clear, it will not show you the clear picture, and instead of that, probably it will end up showing you a hazy picture, for which a confocal microscopy can definitely do a good work. I think I'll finish this thing here, and ASOCT is definitely for the next time.
Thank you very much.